There is a moment most people never forget. You're walking up a flight of stairs, the same stairs you've climbed 1,000 times, and halfway up you have to stop. Your chest feels tight, your legs feel heavy. You grab the railing and tell yourself it's just age catching up. Maybe you even laugh it off to whoever is standing nearby. But here's what nobody told you. Age doesn't do that alone. And if you're currently taking a medication for your blood pressure, one that millions of older adults take every single day without question, there is a very real possibility that the pill you swallowed this morning is playing a direct role in how you feel right now. I want to be careful with how I say what I'm about to say, because this topic deserves precision, not panic. I'm not going to stand here and tell you that your doctor is wrong or that your medication is poison. Medicine is layered. Context matters enormously, and I'd be doing you a genuine disservice to reduce this to a simple villain and hero story. What I am going to tell you is that the scientific conversation around one of the most widely prescribed blood pressure drug classes for older adults has shifted dramatically over the past 2 decades. The evidence has moved, the major guidelines have moved, but for millions of people, the prescription hasn't moved at all. It was written years ago and has been refilled month after month without a single conversation about whether the current science still supports it. That gap between what the research now says and what many patients are still taking is exactly what we need to talk about today. Stay with me, because by the end of this, you'll have something more valuable than a diagnosis or a recommendation. You'll have specific, informed questions that can change the entire direction of your next medical appointment. Let me start with the medication class itself, beta blockers. You may recognize them by their brand names, Metoprolol, Lopressor, Tenormin, or by their generic names, Metoprolol, atenolol, bisoprolol, propranolol, carvedilol. These are among the most frequently prescribed cardiovascular medications in the world. Tens of millions of prescriptions are written every year in the United States alone, and a very significant portion of those prescriptions belong to adults over 60 who have been taking them for years, sometimes for a decade or more, for one reason and one reason only: their blood pressure reading is too high. To understand why this matters, you need to understand what beta blockers actually do inside your body, not at the level of a number on a cuff, but at the level of your cells and your physiology. Your heart has specialized receptors on its surface. Think of these receptors as locks, and think of adrenaline, the hormone your body releases during stress, exertion, and excitement, as the key. When adrenaline binds to those locks, your heart speeds up. It beats harder. It pumps more forcefully. This is your body's built-in response to demand. Beta blockers work by physically occupying those locks. They sit in the receptor and prevent adrenaline from connecting. The result is a slower, less forceful heartbeat, which brings blood pressure down. Simple mechanism, predictable outcome. And for specific medical situations, that mechanism is genuinely valuable. If you've had a heart attack, beta blockers reduce the risk of a second one. If you have a diagnosed condition called heart failure with reduced ejection fraction, they improve survival outcomes. If you have certain dangerous heart rhythm disorders, they help control those rhythms. The evidence for beta blockers in these specific situations is solid, well-established, and not in question here. But here is the pivot point that everything else turns on. What happens when a senior with no history of heart attack, no heart failure, and no rhythm disorder is placed on a beta blocker purely to lower an elevated blood pressure reading and kept on it for years without reassessment? That is a fundamentally different question, and the answer the research has delivered over the past 20 years is one that every older adult on a beta blocker for hypertension deserves to hear. In 2017, the American College of Cardiology and the American Heart Association released updated clinical guidelines for hypertension management. Beta blockers were not listed as a first-line recommended treatment for uncomplicated high blood pressure. That same position is reflected in the 2024 European Society of Cardiology guidelines, which similarly do not position beta blockers as the preferred starting point for most patients with hypertension alone. This isn't a fringe opinion or a contrarian take. This is the considered consensus of the leading cardiovascular medicine organizations in the world after reviewing decades of accumulated evidence. So what shifted the evidence? The story has a turning point, and it came from one of the largest hypertension trials ever conducted. The ASCOT trial, the Anglo-Scandinavian Cardiac Outcomes Trial, was published in The Lancet in 2005. It enrolled 19,257 patients who had high blood pressure and followed them for approximately 5.5 years. This was a rigorous, well-designed study comparing two treatment strategies. One group received a beta blocker-based regimen using atenolol, and the other received a calcium channel blocker-based regimen using amlodipine. The trial was stopped early, not because of a problem, because the results were so clear and so favorable in one direction that the ethics committee determined it would be wrong to keep patients in the beta blocker group when the disparity was that significant. The group receiving the calcium channel blocker had 23% fewer strokes, 11% lower all-cause mortality, meaning fewer deaths from any cause, not just cardiovascular ones, 16% fewer total cardiovascular events, and 30% fewer new cases of type 2 diabetes. Pause on that last number, 30%. When researchers followed up on the ASCOT participants 16 years later, this follow-up study was published in The Lancet in 2018. They found that the survival and stroke reduction advantages in the calcium channel blocker group had persisted over the entire follow-up period. The cardiovascular protection extended more than a decade after the original trial ended. Now, I want to be precise here because precision is what separates useful information from misleading information. The ASCOT trial specifically compared atenolol, an older beta blocker, against amlodipine. Scientific debate has continued about whether all beta blockers share the same outcome profile as atenolol, or whether newer agents like carvedilol and nebivolol, which work through slightly different mechanisms, produce different results. Some evidence suggests they do behave differently. The 2023 update from the European Society of Hypertension retained beta blockers as an optional treatment category, acknowledging the breadth of data on this drug class. The science is still evolving in certain corners, but here is what is not evolving, not debated, and not ambiguous. The quality of life burden of beta blockers in the ASCOT trial was real and substantial. The beta blocker group had twice the rate of fatigue, significantly more bradycardia, an abnormally slow heart rate, more dizziness, more shortness of breath. For someone in their 30s, those side effects are inconvenient. For someone in their 70s, they reshape daily life. They are the difference between a morning walk and skipping the morning walk, between gardening and watching through the window, between feeling like yourself and feeling like a diminished version of yourself. And here is where I want to stay for a moment, because I think this is the part of the conversation that most patients never have. When you go to a doctor's appointment and your blood pressure reading comes back at 124/76, the appointment feels successful. The number looks good. Your physician is reassured. You leave with your prescription refilled and a sense that everything is under control. But a blood pressure number on a cuff measures one thing. It does not measure what is happening inside your metabolism. It does not measure insulin resistance. It does not measure what is happening to your triglycerides or your HDL cholesterol or your fasting blood glucose. And beta blockers have documented, well-studied effects on all of those things. Effects that do not show up in a blood pressure reading, but that accumulate quietly in the background of your health. Here is what the research shows. Beta blockers increase insulin resistance, meaning your cells become less efficient at responding to insulin, the hormone that regulates blood sugar. They raise triglycerides, a type of fat in the bloodstream that, at elevated levels, contributes to cardiovascular disease. They lower HDL cholesterol, the so-called good cholesterol that helps remove harmful cholesterol from your arteries. A large meta-analysis examining data from nearly 95,000 patients found that people taking beta blockers for hypertension had a meaningfully elevated risk of developing new-onset type 2 diabetes compared to patients on other blood pressure medication classes. In the ASCOT trial specifically, the atenolol group had a 30% higher incidence of new diabetes compared to the amlodipine group. Think about what that means in practice. Diabetes and hypertension together, two conditions that each individually raise cardiovascular risk, create a combined risk profile that is substantially greater than either condition alone. The interaction between the two accelerates arterial damage, increases the likelihood of kidney disease, raises the risk of stroke, and compounds over years in ways that a blood pressure reading alone will never capture. So here's the scenario I want you to sit with. A patient is placed on a beta blocker for blood pressure. Their blood pressure comes under control. On the surface, the medication is working, the number looks acceptable, but underneath that surface, insulin resistance is building. Triglycerides are drifting upward. HDL is declining. Fasting blood glucose is rising toward prediabetic territory. 3 or 4 years later, the patient has developed type 2 diabetes, a diagnosis that now adds its own set of cardiovascular risks, medications, and complications to their life. Could that blood pressure medication have contributed to that trajectory? According to the research, the answer may be yes. And yet the conversation connecting those dots almost never happens in a standard appointment. I want to add one more dimension to this that is especially important for older adults specifically, and that is the question of falls. Beta blockers can cause a phenomenon called orthostatic hypotension, a sudden drop in blood pressure that occurs when you stand up from a seated or lying position, that brief dizzy spell when you rise too quickly from a chair or get out of bed. In a younger person, it's mildly uncomfortable and passes within seconds. In a person in their 70s or 80s, it is a fall risk, and falls in that age group are not minor events. Research published in major orthopedic and geriatric medicine journals has documented that hip fractures in adults over 70 carry a 1-year mortality rate approaching 30%. A medication that increases dizziness upon standing, that slows reflexes, that contributes to fatigue and reduced energy. That medication is not just affecting blood pressure, it may be affecting the entire trajectory of a person's physical safety. Now, I want to tell you what the current evidence actually supports as alternatives for seniors managing uncomplicated high blood pressure, because this conversation has to be constructive. 2 medication classes consistently appear in both American and European guidelines as preferred options for this population. The first is calcium channel blockers. Amlodipine is the most widely prescribed agent in this class and the one that performs so clearly in ASCOT. Calcium channel blockers lower blood pressure by relaxing the walls of blood vessels, reducing the resistance the heart has to pump against. They do not carry the same metabolic burden. They do not blunt your maximum heart rate in the same way. They do not increase insulin resistance or negatively affect lipid profiles the way beta blockers do. And as the ASCOT data and its 16-year follow-up showed, their cardiovascular outcome profile is significantly stronger for patients with uncomplicated hypertension. The second class is ACE inhibitors and their closely related family called ARBs, angiotensin receptor blockers. Medications in this group include lisinopril, ramipril, losartan, and valsartan. These drugs work by interfering with a hormonal system that causes blood vessels to constrict and the kidneys to retain fluid, both of which contribute to elevated blood pressure. Beyond their blood pressure effects, ACE inhibitors and ARBs have demonstrated protective benefits for kidney function, particularly relevant for seniors with diabetes or compromised kidney health. A meta-analysis published in the Journal of the American College of Cardiology found that patients taking ACE inhibitors or ARBs had significantly lower rates of new-onset type 2 diabetes compared to patients on other antihypertensive classes. For anyone whose blood sugar is already trending upward, that distinction is clinically meaningful. One practical note: ACE inhibitors cause a persistent dry cough in approximately 10 to 15% of patients due to the accumulation of a substance called bradykinin in the respiratory tract. If you've ever been on an ACE inhibitor and developed a nagging, dry cough that had no other explanation, that may be why. ARBs work through a similar blood pressure lowering pathway, but do not trigger the cough. For patients who cannot tolerate ACE inhibitors, ARBs are typically the next step in the same therapeutic direction. I also want to say something clearly about the patients for whom this conversation does not apply, because context is everything in medicine. If you have a prior history of heart attack, beta blockers reduce your risk of a second cardiac event, and the evidence for that is strong. If you have been diagnosed with heart failure, specifically the type characterized by a reduced ejection fraction, beta blockers improve survival, and that is well established. If you have atrial fibrillation or another arrhythmia where controlling your heart rate is a clinical priority, beta blockers may be doing exactly what they should. If you have coronary artery disease, they play an important role in managing symptoms and preventing events. For all of those patients, the calculation is different. The same medication in a different clinical context has a completely different risk-benefit picture. This is not a story about a medication that is universally bad. It is a story about a medication that may be prescribed to patients who would benefit more from a different approach, and about the absence of conversations that should be happening but often aren't. Before I give you specific steps, I need to say something that I said at the start and will say again. Do not stop taking a beta blocker on your own. This point is not negotiable. Stopping a beta blocker abruptly without medical supervision can trigger a rebound effect. Your heart rate and blood pressure can spike rapidly, and in some cases this rebound can cause a heart attack or a serious arrhythmia. Any transition away from a beta blocker must be done gradually, over a minimum of 4 to 8 weeks, under direct medical supervision with regular monitoring of your heart rate and blood pressure throughout the entire process. Any physician who proposes otherwise is not following safe practice. Please hear this seriously. What I'm offering today is information and language, the tools to have a better, more informed conversation with your doctor, not a license to open your medicine cabinet and make unilateral decisions. Now, here is what you can actually do starting right now. The first step is to identify your medication. Look at your prescription bottle. If the name ends in olol, metoprolol, atenolol, bisoprolol, propranolol, carvedilol, you are on a beta blocker. The next question is why. If your only diagnosis is high blood pressure with no prior heart attack, no heart failure diagnosis, and no heart rhythm disorder, then you are in exactly the situation this conversation addresses. The second step is to write down 3 specific questions before your next appointment and bring them in writing. Ask your doctor, was my beta blocker prescribed specifically for blood pressure control, and does that choice still reflect current ACC/AHA guidelines given my complete health history? Ask, has anyone reviewed my fasting blood glucose, triglycerides, and HDL levels recently in the context of my current medication? And if those markers have been trending in the wrong direction, could my medication be contributing? And ask, given what the evidence now shows about outcomes in seniors with uncomplicated hypertension, am I a candidate for a supervised transition to a calcium channel blocker or an ARB? Those 3 questions will open a very different kind of conversation than a standard blood pressure check usually allows. The third step is to request a formal medication review if your blood pressure prescription has not been systematically reassessed in 2 or more years. Guidelines evolve. Evidence accumulates. What was considered the optimal treatment approach in 2008 may not reflect what the same organizations now recommend in the mid-2020s. Requesting a medication review is not confrontational. It is simply good healthcare practice, and any physician committed to evidence-based medicine should welcome it. The fourth step, if any transition is discussed and agreed upon, is to confirm the tapering plan in explicit detail before you leave the appointment. What is the dose reduction schedule? Over how many weeks? What symptoms should prompt you to call the office? How frequently will your blood pressure and heart rate be checked during the process? There is no acceptable shortcut to a gradual supervised taper. Make sure you understand every step of the process before it begins. And while you are working through that conversation with your doctor, I want to give you something you can do right now, today. without changing a single medication or waiting for any appointment. Lifestyle interventions for blood pressure are not a consolation prize. They are not what you do when nothing else works. They are genuinely powerful tools with strong clinical evidence behind them, and they work alongside whatever medication strategy you and your physician decide on together. 20 minutes of daily walking at a pace that elevates your breathing modestly has been shown across multiple clinical trials to reduce systolic blood pressure by 4 to 9 points. That is a reduction comparable to what some low-dose medications achieve, and it comes with no metabolic downside, only upside. Reduced inflammatory markers, improved insulin sensitivity, better sleep, higher energy, improved balance, which directly reduces fall risk. Reducing sodium intake to under 2,300 milligrams per day produces a clinically meaningful blood pressure reduction for many people. The challenge is that sodium hides in processed foods, restaurant meals, and packaged snacks in quantities that most people never suspect. Reading nutrition labels specifically for sodium content is one of the highest leverage changes a person with high blood pressure can make. The DASH diet, dietary approaches to stop hypertension, emphasizes fruits, vegetables, legumes, whole grains, and low-fat dairy while reducing sodium and saturated fat. A clinical trial published in the New England Journal of Medicine found that hypertensive patients following the DASH pattern reduced their systolic blood pressure by 11 points. That is not a small number. That is a meaningful, measurable change achieved through food choices alone. None of these interventions require a prescription. None of them come with a side effect profile, and all of them compound with good medication management to produce a cardiovascular picture that is genuinely better, not just on the surface of a cuff reading, but in the underlying biology that determines your long-term health. Let me bring this back to where we started, that moment on the stairs, the tiredness that seems to follow you through the day, regardless of how much sleep you got, the weight that has been creeping upward even though your meals haven't really changed, the feeling that your body is operating at a lower capacity than it used to, and the quiet assumption that this is simply what getting older feels like. You now know that there is a documented, research-based reason why a beta blocker can produce exactly those experiences in an aging body. You know that the major cardiovascular guidelines in both the United States and Europe have moved away from recommending this drug class as the first choice for seniors with uncomplicated high blood pressure. You know that alternatives exist, calcium channel blockers, ACE inhibitors, ARBs, with stronger cardiovascular outcome data, more favorable metabolic profiles, and less impact on the energy and physical capacity that determine the actual quality of your daily life. You are not trapped by a prescription that was written years ago and never revisited. You are not obligated to accept fatigue, weight gain, and diminished capacity as the price of controlled blood pressure. You are entitled to walk into your doctor's office with informed, specific questions and to receive answers that reflect what the science actually says today, not what it said 2 decades ago when your prescription was first written. The blood pressure number matters. The medication you use to achieve it matters just as much, and you deserve a treatment plan built on both. Now, here is what I want you to do right before you leave this video. If any part of what you heard today felt important, if it connected to something you've been wondering about or something you've been experiencing that nobody has explained, drop a comment below right now. Tell me the name of the blood pressure medication you're currently taking, or share the question you most want answered. I read every comment personally, and the questions you bring to this channel shape what I cover next. Your question may become the subject of the next video. If you found value in this content, please hit the like button. It genuinely helps this information reach more people who need it. Subscribe to this channel if you haven't already, because we cover topics like this one regularly. The gaps between current evidence and standard practice, the questions patients deserve to be asking but rarely do, and the conversations that can actually change outcomes. Share this with someone you love who has been on blood pressure medication for years without a single conversation about whether today's evidence still supports that choice. Because sometimes one video, one question, one conversation at the right moment is the thing that changes everything.